Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm speaking to Ruth Rankine, who's the Director of Primary Care at the NHS Confederation, about how we can create a neighbourhood NHS and what general practice's role is within that. A key plank of the government's plans is to move towards a neighbourhood NHS with more care provided outside of hospital and in the community. But what does this mean in practice? Integrated care boards are currently working to set up integrated neighbourhood teams, but as yet there's no clear definition of what these teams should look like. In this conversation, I talked to Ruth about how this work is going, how the NHS will need to change if it's going to deliver more services in primary care, and the importance of allowing local areas the flexibility to redesign care in a way that meets the needs of their population. Ruth also talks about how the GP contract may need to change in future to deliver this vision, the important role primary care networks have to play, and the opportunities to create new pathways involving GPs with extended roles. Before we start, just a quick message to say that MIMS Learning Live Digital is taking place online across 4 evenings from the 10th to the 13th of March. If you need some help keeping up to date with clinical practice, our colleagues from our sister site MIMS Learning can help with this series of evening webinars. You will have the chance to earn up to 6 CPD hours from the comfort of your own home or practice, with presentations from expert speakers who are passionate about their areas of expertise. For more information and to register for your free place today, visit mimslearninglive.com/digital. I'm delighted to be joined on the podcast now by Ruth Rankine, who's the Director of Primary Care at the NHS Confederation. Before she joined the NHS Confederation, Ruth was Deputy Chief Inspector of General Practice at the Care Quality Commission. She also has senior management experience in the civil service and the NHS and spent more than 10 years working in the Department of Health. Thanks for coming on the podcast, Ruth.
Thank you for having me.
First of all, for people who don't know, can you explain about what the NHS Confederation does and what the role of the primary care network is?
The NHS Confederation is a membership organisation. So our members are NHS commissioners and providers. We are in England, Wales and Northern Ireland. In England, our members are ICS's acute community mental health providers. And in our primary care network, our members are primary care providers that operate at scale. So primary care networks, GP federations, super partnerships. And then in the last year, we've also, thinking about primary care in the broadest sense, we've brought members in from optometry, audiology, dentistry and pharmacy. So we can really look at primary care in the round. So that's the membership. In terms of our role, as Confed, our role is really sort of threefold. Firstly, it's about influencing government policy, how things get implemented, and advocating on behalf of our members, really bringing our member voice into the heart of policy making. We support our members in lots of different ways. That might be supporting them to improve through our improvement programs or leadership programs, or bringing people together into different forums. And that's about how, them sharing what they're doing, how they're doing it, thinking about solutions to some of the challenges. And then the final part of our role is about connecting people, so connecting members. So we often get members coming, with problems, and we'll be able to connect them with another member that's actually had the same problem and solved it. At a very simple level, that's our role. But we're very focused on how we help the NHS to improve.
While I was preparing for this, I saw a video on your website and you talk about the NHS Confederation creating a vision for the future of primary care where it's connected, respected and empowered and a critical part of their health system. I was wondering if you could explain a bit about where that came from and whether or not you think primary care is in that position at the moment.
It was something we produced in 2023 and it was very much driven by our members. And actually the 3 things that came out loudly in terms of what did people want around the future were to be connected with across primary care, but across the system, to be respected for the important role that they play within the system, and to be empowered to really lead and drive change at a local level. In terms of whether I think primary care is in that position, I think the answer is to some degree, yes, but there are pockets of great things happening and there are pockets where people are really struggling. I feel really, really passionate about the value of primary care and general practice. I see the commitment every day through our members who want to do the right thing, for their communities, their patients, and for the wider system. So I see our job as flying the flag for what primary care can do and is doing. And I think it's easy to dwell on the problems and the challenges, and you get into this circle of doom. We as an organisation really want to showcase where it's working really well, how people are doing it, what other people can learn from it, in a way both to inspire what the policy direction could be. So recently, for example, we've got 2 ICBs, Leicester and Rutland, and Frimley, who've developed an amended funding formula for general practice. That's been in sort of development over the last couple of years. It started in LLR, adopted by Frimley. They're both obviously members of Confed. We've been talking to them. They approached us and said, actually, we'd like to do a webinar to help share what we've done, how we've done it, some of the challenges, but actually, what does this give in terms of additional funding into general practice, particularly where you've got areas of high need. So we put on a webinar, that was open to everyone. We share publicly, but equally through our sort of forums, we will invite people to present what they're doing. Birmingham, Solihull, I've got a fantastic community care collaborative, which is bringing primary and community care together with other parts of the system to really look at ways to promote that.
Primary care is obviously a really big part of the government's plans for the NHS, particularly about this whole idea of how to create a neighbourhood NHS and shift the focus from hospitals to the community. There's already a lot of work going on in integrated care boards around creating these integrated neighbourhood teams. Firstly, just for anyone who's listening who doesn't know what they are, what exactly are integrated neighbourhood teams and why are ICBs setting them up?
I think part of the challenge is everyone's got a slightly different definition of a neighbourhood team. And we tend to talk more about integrated neighbourhood working rather than integrated neighbourhood teams, because I think when you talk about integrated neighbourhood teams, it assumes there's something separate to the sort of the fabric of the infrastructure that's already there. And actually, for me, integrated neighbourhood working is how do you bring together the capacity and expertise from across different parts of the system, not just NHS, but local authority and the voluntary sector, to create and deliver a really personalised, joined-up approach to what care looks like for certain groups of people. Could be specific population groups, or it could be around conditions, such as frailty or mental health. Increasingly, and post-pandemic, we are seeing much greater complexity in terms of people's health needs, and that is showing up in primary care. And not all of those are health needs. The idea that actually, general practice isn't the solution to everything, and we need a much more holistic solution to delivering more person-centred care around the needs of that individual in a joined-up way. And I think the other thing that I would say is that how do you define what a neighbourhood is? So we're doing a big programme of work at the moment in neighbourhood health with an organisation called Local Trust, which is about building up local communities. What they bring to our programme is that real focus on really working closely with communities. What the health service understands as the neighbourhood is not necessarily what someone in a local community understands to be their neighbourhood. If we're going to deliver this in a really person-centred way, we've got to really understand and work with our communities to understand what is it they define as the neighbourhood. And then, of course, all of that needs an infrastructure that supports the delivery of it, whether that be a system in terms of defining a set of priorities that apply across the system, but equally at a place level in terms of enabling that integration between different parts of the system, providing the sort of the back office infrastructure, whether that's leadership support or business intelligence, population health management data, so that type of infrastructure support that then supports the delivery of that care on the ground.
We haven't got the 10-year plan yet, but ICBs have already been kind of working, integrated care systems have already been working on these neighbourhoods and trying to set them up already. What's your sense about how that's going?
I would say every ICB has a strategy for how they want to do it. Do we have a neighbourhood service on a national scale? No, people are still testing out different approaches in different areas, even within systems. It's still evolving. What it looks like is very different, but that's not necessarily wrong. In some areas, it will be very much around frail elderly, those people who've got needs that mean they keep coming back to A&E when actually, they need a whole different solution. We've got models whereby it's literally the neighbourhood is 3 streets where, they've got a team of serving the needs of people in those houses, whether it's elderly, babies, young children, people with long-term conditions. So it looks very, very different across the country. But as I say, if we get this right, we are working with our communities and we are responding to what they need, whether it's public health, mental health, or just social support, that we're working together to provide that.
How do you see general practice fitting into all of this?
So for me, it's absolutely at the heart of this, because we've got list-based general practice, actually, that they feel that responsibility to their patients. Where we struggle is when it goes beyond health in terms of the need. Their ability to access that wider support is hard just because of the pressure that other services are under. The neighbourhood approach means that they are part of that neighbourhood team. In many cases, around the country, primary care is driving the neighbourhood approach. There's lots of PCNs driving it. There's federations kind of driving it in terms of providing that overarching infrastructure, enabling local delivery. We've got community trusts driving it as well. But I think primary care is definitely at the heart of it.
This idea of a neighbourhood NHS, I think part of the reason Wes Street and the government are very keen on it is this idea about moving care away from hospitals into the community, away from treatment towards prevention. So it's pretty key to this whole new model. And proactive care is going to be a really big part of that, isn't it? How do you think things need to change to enable that shift from hospitals to community?
The challenge we've got is the transition, how you sort of build for the future in terms of the infrastructure. And and that could be estates, it could be workforce, it could be data and digital infrastructure that you need for the future, whilst you have to keep the show on the road today. And we know that the economy and the sort of financial climate is incredibly difficult. So I think the transition is the challenge. And again, I think we are seeing pockets of where it is already happening. Many are already working with the local acute trust to deliver services. And we're seeing that in large practices and PCNs as well. Acute trust is actually subcontracting to primary care for the delivery of certain elements of the pathway. Last week, when I visited a large community pharmacy where the acute trust has subcontracted the community pharmacy to provide their medicines discharge service, which means a much faster turnaround for people waiting to be discharged to receive their medicines and leave hospital. There are pockets of it happening, as with lots of these things, but we don't necessarily, obviously, because we haven't got the 10-year plan, we don't have the strategy to make it real. Certainly from our conversations with a number of ICBs, they will say, well, actually, we're measured on our finances and we're measured on our waiting times and we're measured on our A&E performance. And those are the things that we feel that was held to account for most. So actually, if we're serious about care closer to home, then we need to be measured on delivering it. So the question is, what are the sorts of measures that you might put in place to demonstrate that people are really making progress? So that's a piece of work that we're working through at the moment with our members.
So you're actually doing something like that, and that potentially could come out as a paper that could potentially inform things that the government might decide to pick up or not?
Well, our role is how we take what people are doing already that's working really well and making a difference, and building a membership consensus and presenting that as part of our influencing work and our work with the department and NHS England. So I think it's about constantly demonstrating that it can be done. And how do we make sure that we're levelling up rather than levelling down? So how do we make sure that things are ambitious so we get maximum change, but equally they're doable for everyone with support?
The NHS Confederation produced a report last year about neighbourhood NHS and making the case for a neighbourhood NHS. And one of the things that said was that to make this model work would depend on reforms to GP contracts and funding. What changes do you think are needed to the GP contract if we are going to develop this neighbourhood NHS?
First of all, I think we have significant variation in the quality of general practice. From my CQC experience, I know that a lot of that is often outside of the practice's control. So I think we've got to somehow try and make sure there is sufficient funding through the GP contract to a good quality of care across the board. But there's two other dimensions. There are people at one end who are incredibly entrepreneurial and incredibly innovative and doing really fantastic things, over and above the core contract. So we have to find a way of enabling them to continue to do that and to do more. So not to slow down, because that's where we will keep pushing the boundaries in terms of what's possible for general practice. At the other end, there are those that are really struggling, could be for a whole host of reasons. So we need to find a way of supporting them to continue or supporting them to work in a different way. And at the moment, I'm not sure the contract, and certainly if you talk to ICBs, I'm not sure that they would say that they've got the levers to address both of those. So I think the contract needs to respond more to what ICBs need to really commission general practice well.
What sort of changes do you think it needs then to help ICBs do that?
Both incentives for those that are performing. So how do we incentivize people to go further, to do more? Now, that could either be through the sort of the core contract, or that could then be through locally commissioned services, whether it be specific conditions or specific patient groups or the use of digital, so there could be a whole range of things. And when we did our report last year on sort of future changes to the contract, we engaged ICBs in that process along with our primary care members. There is always this question as to what should be nationally mandated versus locally specified. Everyone agreed you still need a set of national priorities so that wherever you live, you can expect the same minimum level of service from your general practice. But equally, people recognised that their ability to commission over and above around the specific needs of their communities was limited, or there may be things within the nationally mandated contract that actually weren't relevant to them. We haven't got that national mandation versus local commissioning, local specification right yet. Streamlining in terms of really focusing on outcomes rather than inputs or processes, thinking about the general practice workforce in terms of the whole workforce. It is about how do we retain a good multidisciplinary workforce within general practice, because with the financial pressures, the private sector, whether it's supermarkets, call centres, whatever, is becoming a more attractive option financially for a lot of people. in those roles. We've got to make it a good environment to work in, and that includes terms and conditions for the staff that work there. The funding formula, and I go back to the webinar that we did with LLR and Frimley. Carhill is 20 years old now, and we know that it doesn't work in a lot of cases, but to rework it is not a short-term job. And there will be consequences. So there would be winners and losers, as there was the last time, as there was when we introduced Carhill formula. We need to find a way, at least in the short term, the ability for ICBs to top up to address particular needs of the community. And that could be around deprivation. It could be rural issues in terms of what's available and how far people have to travel, and the ability to deliver care to people in really rural areas. So the funding has got to be looked at. And I think then in the context of a neighbourhood service, it's got to incentivise general practice to really be part of a neighbourhood health service, to see its role in terms of supporting the delivery of that personalised care, and see the benefit of having access to a wider range of expertise and resources as part of a neighbourhood team.
So you talked there about local funding. Do you think that ICBs need to basically be given a pot of funding that needs to be sort of ring fenced and say that's what you need to spend on primary care? Because obviously the problem we've had in recent years is that inevitably money always gets sucked into hospitals because waiting lists are a disaster and hospitals have breached their budget. If they are going to do something like that, do you think we need to see specifically ring-fence bits of funding for ICBs and saying, yes, you have that money, but you have to spend it on primary care, you have to spend it on general practice?
Ideally, yes. So one of the things that we, along with others, have been calling for is a primary care investment standard in the way that we have in mental health, because I think it is, for any funding that is not committed to primary care through the contract, it is very difficult to protect it for primary care support, transformation, top up. And ICBs are in a really difficult situation. So, I completely get it in terms of how they prioritise and how they have to balance the books. But I think equally they're being put in a difficult situation and being forced to make difficult choices when the direction of travel is more care out of hospital and more investment into primary and community. So yes, that's absolutely one of the things that we would like to see, is whether it's an investment standard or whether it is a target proportion of ICB spend out of hospital.
Do you think that general practice and local systems should be judged more on outcomes rather than processes, maybe, potentially? And if so, how would you see that working?
In short, yes. But this comes back to the freedoms. You set the outcomes that you want to achieve and you let people decide how they're going to deliver those, whether that's in terms of the workforce that delivers the service model or how they work with partners to deliver it. So I just think we've got to move away from this really static process of, we're going to measure you against this outcome, but we're going to tell you exactly how you're going to achieve that outcome, which of course you can't nationally specify that because everywhere is different and everyone works in different ways. So I think definitely much more focus on outcomes and minimum standards rather than prescribing what the model is.
Are you talking about an overhaul of the QOF, maybe the end of the QOF, that sort of thing, different ways of incentivising general practice perhaps in future?
Overhauling the QOF is not a one-year job. And it's interesting because when we engaged with our members last year on changes to the contract, we went in with an assumption that people would say overhaul QOF or get rid of QOF. And actually that wasn't the outcome. I would say small majority felt that it's not perfect, but actually compared to what we've had before, it's better than nothing. So actually not necessarily tweaking, but having a good look at what are the big priorities that we need to be focusing on at a national level with greater flexibility for actually how could we have a localised element of QOF to incentivise for those priorities that we know are needed in this neighbourhood place system. So I think, again, it comes back to that national local. So I think as a framework, it probably works. But the conclusion with that, actually, we want better balance of national and local.
The other big issue at the minute is what happens now with primary care networks as we move forward. What role do you see primary care networks as playing as part of a neighbourhood NHS?
The role for PCNs in the future is really strong as part of a neighbourhood. And I say this lots of times. If you go back to the original vision for PCNs in terms of what they would focus on and the makeup of the PCN and their governance, you could be describing an integrated neighbourhood team. The challenge we've had is that the vision was followed by a very detailed, specified set of instructions about what they would do, who they would employ, and how much they would pay them. So if the vision was great, if it had been followed by the flexibility for primary care networks to truly respond to the needs of their local communities and employ the workforce they needed to employ to deliver those services, we would have seen much greater innovation than they have been enabled to provide. My fear is what we've ended up with is more general practice at scale rather than actually primary care in the truest sense of the word, working with really closely with other parts of the system. Now, there are definitely many, many PCNs around the country, a lot of whom are in our membership, who embody that vision and irrespective of the PCN DES are working in line of that vision, and they're working with their communities and they're delivering neighbourhood care and they're going above and beyond and they're innovative and they're entrepreneurial. But the PCN DES has not helped us. So, my strong view is that if we had implemented PCNs in the right way, we wouldn't be sitting here today talking about INTs.
Some GPs, when I speak to people, they say all of this stuff is quite a lot of work, like reorganising, coming up with neighbours. They say people are constantly going to meetings about this and there's a lot of scepticism in some quarters about actually whether it's going to make a difference.
I'm a glass half full type of person. I've worked in the department. I've developed policy. I think more than ever, the front line is involved in a lot of conversations about future policy. If you think about the process around the 10-year plan, the red tape challenge, all of those groups have got frontline people at the heart. Of course, that doesn't guarantee, whatever they say ends up in national policy, but it's more than it's ever been. And I think we've got an opportunity, and I think we've got a government which is absolutely committed to prevention and care closer to home. I believe that we've got ICBs, chief executives, chairs and directors of primary care who are committed to care closer to home and general practice. So we've got the right people to make it happen. But I go back to where I started. We can't keep coming up with the problems. We've got to come up with the solutions, and we've got to show how people are delivering it now, despite all of the problems and all of the challenges. And it takes sheer determination, hard work, leadership. And a lot of people do this in their own time and at weekends because they believe passionately it's the right thing to do. And I think sums up general practice and primary care generally is that it's full of people who do things because they believe it's the right thing to do and will therefore put the effort in to make it happen. I think the national narrative is positive. Obviously, we continue to push for the action that delivers the narrative, and we will continue to work with our members to really bring forward the ideas that they've got, the work that they're doing at a local level that's absolutely in line with this direction of travel.
A big part of this is going to be what's in the 10-year plan, because obviously that's going to set the direction. That's going to be what integrated care systems are going to have to follow, what's in the 10-year plan. What do you hope will be in that plan?
I would like to see greater autonomy and flexibility at a local level. System, place, neighbourhood, general practice, PCN, federation, which then enables people to have the freedom to really engage with communities and to co-design what the future looks like for that neighbourhood, for that place. Getting the balance right between what's nationally mandated and what's left for local autonomy and flexibility. I think not an over-specification on what a neighbourhood health service is. So a set of national minimum standards, allowing then systems and places and neighbourhoods to define what that means in their context, because the provider landscape looks very different and communities are very different. I'd like to see a commitment to the investment that will be put into out-of-hospital care. The detail of that's unlikely to be in the plan, but certainly followed up through the spending review. But at least that, ideally, a number which sets a percentage of investment that people want to see in out-of-hospital care, and a commitment to really investing in the primary care workforce, supporting retention, not just of GPs, practice nurses, non-clinicians as well. We've got managers in primary care that see secondary care now as a much more attractive proposition. So investment in the workforce. And I think that really investment for leadership and OD support for primary care that we've never really had in the same way that secondary care has had, recognising that it is part of the NHS. And there are fantastic leaders out there, some who can do it on their own, but actually there's fantastic emerging leaders. So we need the right support for that leadership and organisational development. Because when I go around the country and see all the great stuff people are doing, and you sort of talk about, well, how did you do it, whatever, but the number one thing where it starts is with the leadership and people who are prepared to go outside their comfort zone, have difficult conversations, make decisions, work in their own time to make it happen. It's absolutely fundamental to improving services for the future.
Obviously, waiting lists are a huge problem facing the NHS, and inevitably the government is going to be very focused on trying to get down those waiting lists. Are you concerned that a real focus on that is going to make it very difficult for systems and the government to have the bandwidth to kind of focus on this shift to the community? Or do you think the NHS can do both of them at the same time?
So I'm pleased that the elective reform plan recognised that elective waiting lists are not just a secondary care problem. Because I think with all of this, there is a system response. So we did a piece of work last year with some PCN pilots where they worked with their local trust to validate their referral to treat waiting list. And we had a number of different specialties. And it was a senior sort of experienced GP that was doing the validation. And we saw some really impressive results. A lot of people were taken off because actually they'd had the operation elsewhere, or actually their symptoms had changed, so they no longer needed to be on the waiting list. One of the key pieces of feedback that came back was just the patient having that conversation with a GP who really understood their condition and was able to give them assurance, rather than that being an administrative conversation, made a huge difference. So I think that there is a role for primary care in supporting waiting list reduction. Now, we didn't actually see that in this plan. So actually, I would have liked to have seen that go further in terms of actually funding primary care to do waiting list validation. I think, again, it demonstrates the government's commitment to think more about the system, to think about the role that primary care can play, albeit in this case, in a relatively small way. There is still a capacity issue in primary care, and general practice particularly, feels that there is potential further blocks being put in the way in terms of its ability to refer people, which means it has to do more itself, but also, whether those referrals are sent back through advice and guidance and how much of that is coming back on primary care in terms of the workload. So I think there's still a lot of work to do to make it a smooth process around advice and guidance. But equally in terms of, thinking about the focus on future specialties and pathways, we've got to see any pathway pathway redesign with a multi-professional approach. So it can't just be secondary care redesigning a pathway that has an impact on the community. We see massive benefit when we see that primary care community, obviously depending on the specialty and the pathway, but that multi-clinical professional approach to really looking at the pathway and thinking how it could be delivered differently, how we push as much or pull as much of it as possible outside of the hospital. But equally, is there an opportunity for more digital component to the pathway?
If we're starting to move more into the community, do you think that we're going to start seeing more GPs with extended roles in particular clinical specialties? Is that how you see things developing?
We've got to have a good career pathway for GPs that recognises both how the service model is changing in terms of more care coming outside of hospital, but also recognising that how GPs of the future want to work. You know, in a modern society, we should have the flexibility to be able to create that environment for the workforce, which retains them within the workforce and really maximises their sort of skills and experience. So I do think in the context of care closer to home that, and there are already lots of GPs with special interests out there sort of, working in that intermediate space, either sort of being a referral gateway or providing that sort of out of hospital service around certain specialties, and with real success in terms of actually reducing demand and what ends up in secondary care, but equally acting as a sort of a training resource for the primary care workforce in terms of that particular specialty or that pathway. It's inevitable that we will need a different mix of GP workforce for the future, which I think is a good thing. And there is definitely a big interest in that sort of intermediate space between general practice and secondary care, where people can develop new skills and keep them in the workforce.
Thank you so much for coming on the podcast, Ruth. I really appreciate it.
Thank you for having me.
Well, that's it for this week. Thanks so much to Ruth for taking the time to talk with me, and thank you for listening. I'll be back next week for our regular news review. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.